Hi, I'm Rykiel Levine, and this is the rate of renitrogenation after maximal denitrogenation in healthy volunteers. I have no conflicts of interest. So for some background, at sea level, the breakdown of major physiologic gases are roughly 78% nitrogen, 21% oxygen, and less than 1% of carbon dioxide. During normal respiration in healthy lungs, our lungs mimic these numbers and are filled with the same 78% nitrogen, 21% of oxygen, and less than 1% of CO2. Clinically, 21% of oxygen is the FiO2 when discussing lung physiology and pathophysiology when handling sick patients. Our goal as emergency medicine doctors is to optimize this by pre-oxygenating our patients prior to intubation. Preoxygenation is the administration of 100% FiO2 applied to a patient, either via non-rebreather, BiPAP machine, or BVM for a minimum of 3 minutes during normal respiration. The guidelines put forth by the Difficult Airway Society recommend pre-oxygenating, or washout, to an end-tidal O2 of 85% in critically ill patients. Nitrogen levels decrease and carbon dioxide remains low. And again, the illustration demonstrates this distribution after pre-oxygenation. This process is also called denitrogenation due to oxygen washout of the nitrogen in the lungs. Once maximal pre-oxygenation or denitrogenation is reached, induction occurs and the patient eventually becomes paralyzed and apneic. During this time, practitioners may prematurely remove oxygen, and the patient may take 2 to 3 breaths on their own before becoming fully apneic. Oxygen may not be flowing into their lungs, and they will lose the greater than 85% oxygen level of pre-oxygenation just delivered to them with these breaths. Our objectives. Our goal was to determine the rate of renitrogenation in healthy volunteers after optimal pre-oxygenation. We defined optimal pre-oxygenation as an end-tidal O2 greater than or equal to 85%. Again, this is per guidelines by the Difficult Airway Society. We developed a prospective observational volunteer study in which we recruited 50 healthy volunteers between the ages of 20 and 40. We pre-oxygenated each volunteer for 3 minutes or greater until the end-tidal O2 was at minimum 85%. We then turned off the oxygen and recorded the end-tidal O2 every 5 seconds as the volunteers gradually returned to their baseline. This was done in both the seated and supine positions. Here we have a close-up of the monitor during our data collection. The green line at the top represents the volunteer's end-tidal O2 progressively decreasing on room air, and the white line is their end-tidal CO2. This number is the patient's end-tidal O2 at that point in time. This was the number we were recording every 5 seconds. Below that, we have the fraction of inspired O2 that is being supplied to the patient. In the experiment, during data collection, when the patient was expiring, the FiO2 was really 21%, or room air, due to oxygen being turned off. This image does not depict that perfectly. Below this number is the end-tidal CO2 of the patient, which is unchanging and greater than 1% because this is the offload from the patient's metabolics. In our study, 28 out of 50 of the volunteers were female. The median age was 29 with a range of 26 to 31. The average BMI was 24.5 and all volunteers were non-smokers. Baseline end-tidal O2 average was 16%. Only one of the volunteers had asthma, but no others had lung diseases. Our results are shown here in the graph, with end-tidal O2 along the y-axis and time along the x-axis. Clearly, we see how quickly and uniformly the volunteers dropped their end-tidal O2. Renitrogenation occurred in less than 160 seconds for all volunteers, with a loss of greater than 50% of washout in less than 60 seconds. Colleagues in Australia have conducted the same experiment with 30 volunteers, and in this graph, we see our combined data, which shows an even more dramatic rate of renitrogenation. As demonstrated by our data, renitrogenation in healthy volunteers occurs rapidly and significantly faster than pre-oxygenation, almost 1 to 2 breaths. In the setting of the presence of shunt physiology, like pulmonary sepsis, pulmonary edema, or CHF, one would expect this rate to occur even sooner in critically ill patients. There is a high probability of these patients losing oxygen if they take multiple breaths during induction, or even if the mask seal is broken. If healthy volunteers renitrogenate this quickly, it provides insight into sick patients with damaged lungs, with both a reduction of FiO2 due to the inspiration of room air during the early stages of the apneic period, as well as the increased oxygen demand of the ill patient. It can be assumed that these patients would renitrogenate even faster. Prior to laryngoscopy, if room air is mixing into the functional residual capacity of an ill patient, pre-oxygenation efforts may be lost. Additionally, it appears the position of the subject makes no difference in pre-oxygenation or deoxygenation. Further studies would be useful for better understanding the process of denitrogenation and renitrogenation in critically ill patients. Thank you.